Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. And this is going to be the last session. And so today I would like to welcome you all for this debate session, where we are gathered to discuss the revolutionary classes of the medication that's been involved and being used for the management of the type 2 diabetes. That includes the SGLT2 inhibitors and the GLP-1 analogs. As you all know that SGLT2 inhibitors, they have revolutionized the treatment of the diabetes by providing the novel mechanism, and the GLP-1 analogs have demonstrated exceptional efficacy when it comes to the management, along with the weight management and the cardiovascular benefits. So today, our esteemed panel of experts will be engaging in a thought-provoking debate and exploring the clinical efficacy, safety, and the potential applications of these therapies. So before before I start the debate, I would like to call our esteemed panel of experts. First of all, I would like to call Dr. Ahmad Imran Siddiqui. He's the consultant in diabetes and endocrinology, and nowadays working in Shaukat Khanum Hospital, Lahore. Sir, kindly. Our next expert is Dr. Maliha Hamid. She is Assistant Professor, LGH, AMC, Lahore, Pakistan. And I would like to call her, kindly join the stage. The third expert panelist, Dr. Sadia Salman, and she is the consultant endocrinologist and the head of endocrinology department, Allama Iqbal Medical College. Ma'am, kindly come. So before I'll start the debate, I would like to take a quick poll. Like you all been using these therapies. So what do you think? How many of you vote in the favor of SGLT2 over GLP-1? Can you please raise your hands? And how many of you vote for the GLP-1 over when it comes to the So we have poll results now. And how many of you advocate both the medication? So we have the end of the debate. Anyways, the first talk, I would like to call Professor Rayaz Malik. He's the Professor of Medicine at the Weill Cornell Medicine, Qatar. Sir, kindly please come. And he'll be favoring the SGLT2. He'll be discussing the role of the GLP-1. Thank you.
Assalamu alaikum, everybody. So, let the battle begin. Kya? So, Hamid, you can be Foreman, and I can be Muhammad Ali. Okay? So, the debate is GLP-1 or SGLT2. My quote is from Julius Caesar, which is, "Men and women are nearly always willing to believe what they wish." And I must say, when Oscar asked me to do this debate, I went a sigh of relief when he said to me, "You can do GLP-1s as opposed to SGLT2s. Do you not like him? Huh? You must like me. Okay. So anyway, so I had honestly the easiest task, I think. And this is how I want you to remember my talk. Oh. So this is a battle. That could be me, but not, maybe not. Okay. All right. So you've got the general gist, right? It says good against evil. Okay. So, first of all, context. we are here today debating about two drugs which actually weren't around maybe more than 10 years ago, okay? And I believe, and I like quotes, Charles Dickens said in 1859, it was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. So if you're going to use your wisdom, then you will choose only one drug, class of drugs. But how did we get here? Well, 100 years ago, insulin came along, then sulfonylureas, then biguanides, then a whole bunch of other drugs. But really, where we got new drugs was in the last 20 years. The first of the GLP-1 agonists actually came before the SGLT2s in 2005. SGLT2s came along in 2013, and actually, if you look, subsequently, there have been no further real innovations for SGLT2 inhibitors, but the incretin axis has exploded, right? And that tells you that this is the mechanism we need to be exploiting. So, and if you look at incretin history, a lot of people say, well, GLP-1s, they've not been around for that long, and side effects. Actually, the history is very interesting, because if you 1905 is when the first gut hormone, was discovered that it might stimulate the endocrine pancreas. McIntyre and Elric in 1964, 60 years ago, demonstrated the glucose-dependent effect of incretin, GLP-1. GIP was discovered in 1973, and of course, Habner in Boston discovered GLP-1, in 1987. And that's where the first of these drugs came along. So, what do we want to achieve in a drug for diabetes? What's the number one thing you're trying to achieve? Lower glucose. Yes? Maybe you might want to reduce glucose variability, but I woc say HbA1c. So this is actually an analysis that's published last year, 40 studies of different glucose-lowering drugs, 26,000 patients. What did it show? Well, doesn't read very well for you, Hamid. Tirzepatide, 2%, 1.86%, 1.63%. Can anybody see SGLT2s anywhere? Oh dear. 0.46%. So if you want to lower glucose, SGLT2 really isn't the drug that you should be going for. Yes? No? Okay, no, maybe you'll have different slides, but this is pretty good data, it's 26,000 patients. But the bottom line, what's the bottom line? Well, this is the bottom line. This is Jocelyn, and he said, from an excess of fat, diabetes begins, and from an excess of fat, diabetic patients die. And that is the bottom line. It's weight. And that is where there is no competition. So if you look at different GLP-1 therapies, semaglutide, I believe, so far is probably the best of the GLP-1 agonists. What you see very clearly is that if you take patients who are about 100 kilograms, people who are about 100 kilograms, some of them actually 40% have pre-diabetes. They're overweight though, they don't have diabetes. What happens to their weight? Well, the weight, on average, about 16 kilograms. So there's no doubt that if you put somebody on a GLP-1 agonist, they will lose weight. And, in fact, 32% will lose more than 20 kilograms in weight. And, as a consequence, HbA1c, you will actually cure people with pre-diabetes and put them into what I call remission. In about 84% of patients will achieve an HbA1c less than 5.7%. So not only will you have weight loss, you will have normalization of glucose. So that's semaglutide. What about tirzepatide? Tirzepatide, look at the age, 40 odd, weight around 100 kilograms, pre-diabetes around 40%, weight loss, now you've got weight losses of 22 kilograms in the highest dose. And more than 25 kilograms you've lost in the highest, about 30 odd percent. So this is effective weight loss. And what happens to the diabetes? Well, 95% of people who had pre-diabetes are now cured of their pre-diabetes. And it doesn't stop there. So that's single agonist, dual agonist, and now triple agonist. 338 adults. These are more, you can see they're now heavier, 108 kilograms. And this is the triple agonist, so it's GLP-1, GIP, but also glucagon. Much more effective weight loss within 48 weeks, 24 kilograms on average. But this is the best bit. Just look here. More than 30%, i.e. about 30 kilograms weight loss in the highest dose in 26 patients. And 72% of these patients were cured of their pre-diabetes. So, is it a cure for type 2 diabetes? I believe so. And actually, here's a case. This is happens to be, which is why now I can go in and out of Hamad Airport with no problems, right? Because this is the private security to the Emir himself. So he gets, this poor guy, 37-year-old, gets diagnosed with type 2 diabetes. He goes to see Hamad. No, he doesn't. He goes to see somebody else in Doha because his HbA1c is 11.8%. His actually weight is 110 kilograms, but I must say he's about 6.5 feet. So there's a lot of muscle there as well. But he's overweight. And he goes to see somebody, and they put him on the usual metformin, sitagliptin. They put him on an SGLT2 inhibitor, but because his HbA1c is so high, they also put him on insulin. What do you think happens? Not very much. HbA1c drops a little bit. He puts on weight. And then actually, I ended up doing his antibodies because he was relatively young, and you can see he's anti-GAD negative, he's still producing C-peptide. And that's when I was asked to see him from the minister. So I actually put him on semaglutide. I did cheat a little bit. I put him on DAPA as well. And I also gave him one bit of advice, which is what I would give to anybody out there who wants to lose weight. Eat once a day, right? My wife's sitting in the audience, she's thinking, yeah, what an idiot, right? But honestly, alhamdulillah, that's all I've done. I eat once a day now, right? That's the best bit of advice I can give you. And what happened? He actually lost weight, went down to 98 kilograms, but then he got onto tirzepatide, continued his dapagliflozin, and he went, and in November 2023, actually, he went, because he's part of the Emir's personal security, he had to go to desert training in Kuwait. And because of that, he lost more weight. What do you think happened to his HbA1c? Why do you think he thinks I'm so good? HbA1c 5.6%. He's very happy. I'm very happy because for the first time I feel like a surgeon. I've actually done something. I've cured this guy. And now I'm his best friend. So he invites me to his camps. It's brilliant. So some perks of supporting GLP-1 use. But beyond HbA1c, we know that the GLP-1 agonists lower blood pressure, lower triglycerides, they make you look better, and they also lower fat content. What do they do? So this is actually tirzepatide data, visceral adipose tissue, and abdominal subcutaneous adipose tissue. So this is subcutaneous tissue, adipose tissue. This is an MRI. This is visceral. Visceral adipose tissue, if you're on different doses of tirzepatide, you can see significantly goes down. Of course, if you're on insulin, it goes up. Subcutaneous tissue also goes down significantly. And both of these go down, but of course, liver fat content, this is the liver fat content, you can see markedly goes down with tirzepatide compared to degludec. So you've got a treatment which is going to make you look better, but is also going to be physiologically much better for you in terms of whether it's NASH, MASH, and subcutaneous fat. But the bottom line, I guess, is, and I'm sure Hamid will show you this, is what happens to the real things that matter to the patient, right, in terms of cardiovascular and renal outcomes. And so here, you need to, again, look at the evidence, which is GLP-1 receptors against SGLT2 inhibitors. So what does the evidence show? Cardiovascular outcomes, comparable. So MACE is comparable. Cardiovascular mortality, comparable. GLP-1 against SGLT2 for myocardial infarction, comparable. Stroke, however, GLP-1 is better. Mortality, comparable. Where SGLT2 inhibitors previously had an advantage was for hospitalization for heart failure and kidney outcomes. So, cardiovascular, comparable. Stroke, better for GLP-1. However, heart failure, better for SGLT2. Kidney outcomes, better for SGLT2. Until this year. We now have data from STEP HFpEF, which is a large trial in type 2 diabetes in patients who've got heart failure with preserved ejection fraction that is now positive, that shows an improvement of about 20%. And we have FLOW, also published in the New England Journal of Medicine, which again was with semaglutide GLP-1 showing a positive impact. So I believe if I was to redo this now, actually this would move here and this would move over here. So no difference in terms of the hard endpoints. So beyond type 2 diabetes, I also want you to be aware of possible use in type 1 diabetes. So this is actually a case that we've published where 34-year-old lady with type 1 diabetes, a little bit overweight, I put her on semaglutide, okay, 1 milligram. What happened to her weight? Well, she wasn't particularly overweight, but went down by about 8 kilograms. Percent fat went down. Visceral fat went down. Metabolic age improved. So she was 34, but her metabolic age, because of this, actually improved. She was almost 20. So it can even make you younger. And Amr talked about time in range. Well, she actually reduced her insulin dose by about 30%. Despite that, actually her time in range improved. So her glucose variability improved significantly. And the best, honestly, data, this is amazing. When I saw this data published in the New England Journal of Medicine, I thought, wow, this is going to change what we do for type 1 diabetes. Semaglutide in early type 1 diabetes. These are recently diagnosed type 1 diabetic patients, 10 of them. 4 of them had DKA, all of them have got antibodies. HbA1c is 11.7%, on insulin, started with very low dose semaglutide and given for 12 months, 0.125 to 0.5 milligrams. Look what happened to their HbA1c. And you might say, well, HbA1c is going to come down anyway because they're on insulin. But are they on insulin? No. Prandial insulin was eliminated in all the patients within 3 months. Basal insulin was eliminated in 7 patients within 6 months. And then these doses were maintained until the end of the 12-month follow-up. So despite not being on insulin, a type 1 diabetic patient, just on semaglutide, they had already normalized with a HbA1c of 5.7%, and, Amr, for you, time in range, 89%. But what about other additional benefits? So this is a paper published in 2011, and it's actually from some friends of mine in San Diego. And when they were publishing it, when they were doing the study, it was in rats. And they sent me the data, and I thought, this doesn't make sense. And the sense it didn't make is that they'd taken type 1 diabetic rats, given them exenatide, okay? What you see is no change in weight, no change in glucose, which is what you'd expect, because this is not having an effect on the incretin axis. But the surprising finding was that they were regenerating their nerve fibers, right? Intraepidermal nerve fibers were starting to repair, but they couldn't work out a mechanism. Well, the mechanism is that the dorsal root ganglion actually, now they showed, actually had GLP-1 receptors. And we have data, tenuous it might be, from LEADER, which shows there is actually a reduction in amputation rates in those people who are on GLP-1, liraglutide, as opposed to on the placebo arm. And we have data now from Qatar which shows that if you give people either basal bolus insulin or exenatide once weekly, you can lower their glucose to normal, but you can also repair nerve fibers. And this is regeneration of nerves with GLP-1. We have an ongoing study with semaglutide, which shows in patients with type 2 diabetes or overweight, you can lose weight, you improve the HbA1c, but we also show an improvement in nerve fibers, so regeneration of nerves, with an increase in branch density within 3 and 6 months. So, we now know that apart from GLP-1 receptors in relation to glucose control, they are expressed on dorsal root ganglion, but they are also expressed on the brain. And that's where it gets interesting. There is now data, initially again in animal studies, that showed that GLP-1 might have an impact on a mouse model of Parkinson's. Then, in 2017, in the Lancet, there was a paper that showed that if you put people on once weekly exenatide with Parkinson's, you get an improvement in terms of dopa expression in the brain, but look what happens here. You get, this is the placebo arm, this is the arm on GLP-1. You get an improvement in motor scores. And just now, published in the New England Journal of Medicine, is a larger study of 177 people with Parkinson's, 59 years old, on maximal drug therapy for Parkinson's. Look what happens to the motor score. It goes in the placebo 3, it goes down in the lixisenatide arm by 3 marks. In the secondary endpoint, the best thing is this. This is after they've stopped the therapy, 2 months washout, it remains down. So there's something unique going on here in terms of GLP-1 in the brain. And lastly, GLP-1 and Alzheimer's, LEADER, SUSTAIN 6 and PIONEER 6 all showed that if you're on GLP-1, you are less likely to develop dementia. Post-hoc analysis, 3 double-blind outcome trials, liraglutide or semaglutide, in patients with type 2 diabetes, there was a positive benefit. And now there are actually 2 large trials, EVOKE Plus, have already recruited, and they will report next year, inshallah. And the primary endpoint is actually going to be looking at not glucose, not weight, but dementia. Thank you. So, Hamid, the man who views the world at 50, the same as he did at 20, has wasted 30 years of his life.
Did you see him dodging that? Did you see, Ali? Like, how did that?
Aja.
Thank you.
Okay.
So, go ahead, after you.
Thank you, Dr. Rayaz, for such a wonderful talk.